You know how sometimes really small, seemingly unconnected symptoms can actually uh, point towards something quite specific,
Absolutely.
especially when you're revising for the MSRA, right? Making those connections quickly is, well, it's crucial.
It really is. Efficiency is key.
So let's dive into a really high-yield condition for the exams, Plummer-Vinson syndrome. You might also see it as Patterson-Kelly syndrome.
Right, same thing.
Our mission, basically, is to pull out the absolute must-know info from these revision notes, get it locked in for recall.
Exactly. Think of this as your focused revision burst. We'll hit the critical points for understanding and, importantly, remembering PVS.
Okay, perfect. Let's start at the beginning.
Yeah.
What actually is Plummer-Vinson syndrome? What defines it?
It really boils down to a classic triad of features. You've got iron-deficiency, anemia, esophageal webs.
Webs, like thin membranes?
Exactly. Thin membranes inside the esophagus that, well, they make swallowing difficult. That's dysphagia. And the third thing is glossitis.
Glossitis.
Yeah.
Inflammation of the tongue, right? Make it look smooth.
That's the one. So a good mnemonic to hold on to is AWebG. Anemia, web, glossitis.
AWebG. Okay, that's helpful. Symbol. So what causes it? Do we know?
Well, the exact cause isn't fully pinned down, unfortunately. It seems to be multifactorial.
Meaning multiple things contributing.
Precisely. Iron deficiency is definitely a major player. Poor nutrition likely contributes too. And there's some thought, maybe a genetic predisposition in some people.
Interesting. And are there other conditions that often sort of show up alongside it?
Yes. Definitely worth knowing for context. We sometimes see associations with things like Coeliac disease, IBD, pernicious anemia, even thyroid disease, Sjögren's, and rheumatoid arthritis.
Quite a list. Good to keep in mind. So thinking about risk factors, who's most likely to develop this?
It kind of circles back to what we just mentioned. The main risk factors are having the iron deficiency anemia already, poor overall nutrition, and any conditions causing malabsorption.
Right, makes sense. Okay, let's talk pathophysiology. What's actually happening in the body? What's the sequence?
The leading theory suggests that chronic long-term iron deficiency leads to changes in the lining of the esophagus, the mucosa.
Okay.
And over time, these changes are thought to result in the formation of those webs we mentioned. But the precise cellular mechanisms still being worked out.
Still a bit of a mystery then. So if a patient comes in with symptoms that fit this picture, what else should be on our differential diagnosis list? What could it be mistaken for?
Good point. Especially for exams. You definitely consider straightforward iron deficiency anemia, but without the webs or the glossitis.
That's the anemia part.
Exactly. Also, esophageal strictures from other causes, other reasons for dysphagia generally, and other things that cause glossitis. Got to rule those out.
Okay, important distinctions. What about epidemiology?
Yeah.
How common is this, really? Are we likely to see it often in the UK?
In the UK, it's actually considered rare, and it seems to be getting rarer, particularly in developed countries. It used to be seen more in middle-aged women.
Used to be.
Yeah, less common now. But interestingly, if you look globally, especially, say, in the Indian subcontinent, it's encountered more frequently. And there it seems to affect both men and women more equally.
Huh. That is an interesting difference. Okay, clinical features. What might a patient actually complain of? Symptoms.
Think fatigue and weakness, the classic tired twins of anemia. Pallor, obviously looking pale.
All right.
Then the dysphagia, trouble swallowing. Often it starts with solids, then maybe progresses to liquids. Unexplained weight loss can happen too, and sometimes a globus sensation.
That feeling of a lump in the throat.
Exactly that feeling.
And what signs might we pick up on examination?
Well, again, you might see the pallor, tachycardia, a fast heart rate. Look closely at the nails for Coeliac.
Spoon nails. That's a good visual.
It is. And angular cheilitis, those cracks at the corners of the mouth. And, of course, the glossitis, that smooth-looking tongue.
Okay, lots to look for. So how do we confirm it? Investigations.
You'd start with bloods, a full blood count, FBC, and definitely ferritin levels to check for that iron deficiency and the characteristic microcytic anemia, small red cells.
Standard anemia workup.
Pretty much. Then, to actually see the esophageal webs, you need imaging. Things like a barium swallow or an OGD, that's the upper endoscopy.
Hook down the throat.
Yep. And maybe video fluoroscopy. And if there's any suspicion of malignancy, a biopsy during the OGD is needed.
Right, makes sense. So diagnosis confirmed. What's the management plan?
The absolute key is iron supplementation, usually oral iron tablets. Sometimes long-term treatment is required.
Just replace the iron.
Fundamentally, yes. But also, and this is crucial, because of that cancer risk we mentioned, regular endoscopic surveillance OGDs is really important.
Keep an eye out for changes.
Exactly. And if the dysphagia is really bothering the patient because of the webs, you can do mechanical interventions like dilatation, stretching the web, or sometimes argon plasma coagulation.
Okay, so what's the overall picture? Prognosis. And remind us about the main complications.
Generally, with treatment, the prognosis is actually quite favorable. The symptoms usually improve significantly with iron.
That's good.
It is. But the big thing to remember, the main complication, is that increased long-term risk of esophageal cancer, specifically squamous cell carcinoma, especially if it goes untreated. That's why the surveillance is so vital.
Understood. So, key takeaways for revision. Plummer-Vinson, AWebG, anemia, webs, glossitis. Treat the iron deficiency. Monitor closely with endoscopy. That prevents complications like cancer.
That's the core message.
Okay, so a final thought for everyone listening and revising. Considering how these, seemingly minor symptoms cluster together, what other sets of seemingly unrelated findings should always make you pause and think, could this be a specific syndrome?
That's a great question to keep in mind. Really sharpens those diagnostic skills. And of course, for more dedicated MSRA revision resources, do check out PassThemSRA.com and FreemSRA.com.
Excellent resources. Definitely worth a look.